PQRS measures options for pancreatic disease specialists. I'm Darwin Conwell from Ohio State University. This has been prepared by myself and David Whitcomb from the University of Pittsburgh Medical Center. And we're pleased to have Carol O'Brien from AbbVie, who's going to educate us on the PQRS measures, and she's been helping us develop measures specific for pancreatic disease specialists. So now I'm going to turn it over to Carol.
Thank you, Dr. Conwell, and good evening to the CAPER and Pancreas Fest pancreatic disease specialists who are joining us this evening. I'd like to thank Dr. Conwell and Dr. David Whitcomb and Dr. Amir Gugal for their leadership in providing us access to this webinar this evening. I hope you find this webinar enlightening and informational. We will be talking about the need to change pancreatic disease specialist practice to ensure compliance with the new Medicare PQRS quality metrics requirements, and also to provide you with valuable information on Medicare and commercial payers change to value-based payment, which will have a very major impact on all healthcare professionals across the country, and will certainly represent part of the Affordable Care Act's changing healthcare landscape and one of the largest and most significant paradigm shifts in healthcare delivery and healthcare practice certainly in our lifetime. So we will now be moving into the presentation, and we certainly look forward to your questions. So this part of the presentation will focus, as we mentioned, on Medicare's Physician Quality Reporting System, also known as PQRS, and the new value-based payment modifier payment impact on specialists starting in 2015 and going forward. The first slide here represents an example of our new Medicare PQRS and value-based payment guide that we partnered with the American Gastroenterological Association, the AGA, to develop and distribute to gastroenterologists across the country. You can see in the lower right-hand corner of this brochure that the AGA logo is affixed there. This is also on the AGA website, and we're very pleased that AbbVie and our Division of Healthcare Policy was able to partner with the AGA to provide this resource. One of the goals of our meeting tonight and working with CAPER and Dr. Conwell and Dr. Whitcomb is to develop a similar guide for pancreatic disease specialists. Now, what is value-based payment, and why is it affecting healthcare so dramatically? Well, under the Affordable Care Act, the Secretary of Health and Human Services was directed to develop and implement a new budget-neutral payment system. This budget-neutral payment system employs a value-based payment methodology that will actually adjust Medicare physician fee schedule payments starting now and in the future based on two requirements: the quality of care provided by the practitioner and the cost of care that pancreatic disease specialists deliver to Medicare beneficiaries. It's important to note that this new system is budget neutral. What that means is that there is only a set amount of budget or dollars that will be applied to Medicare reimbursement. Those physicians who are agile and able to adapt to this new system will get more of that budget, will get more of that reimbursement or payment at the expense of those physicians who are not able to adjust or adapt to this new system. So very important for physicians to adapt as quickly as they can or be as well prepared as they can for this development. Cost centers will also be an important consideration for those members of the pancreatic disease community who are affiliated with academic medical centers. This could be a significant issue for these large healthcare systems because the cost centers will be highly scrutinized under value-based payment, and Medicare will be looking at hospital procedures, ER visits, but especially hospital-based procedures that Medicare believes could be more cost-effectively provided in an outpatient setting or an office setting. Finally, and perhaps the most surprising or the most dynamic or dramatic change that will affect all physicians and eventually next year all healthcare professionals will be that payment will now be based in Medicare, and many commercial payers are also following similar practices, will now be based on the national mean cost of care for that specialty. So what Medicare will be doing is evaluating the total cost of care per Medicare beneficiary. They will be evaluating the cost of care for gastroenterologists or pancreatic disease specialists based on the national mean cost for that specialty. Medicare will risk adjust for the patients that that practitioner is seeing. It will also adjust for geographic practice expenses because Medicare understands that it's much more expensive to practice in New York City than it is in Evansville, Indiana, for example. Nevertheless, they will be looking at the national mean cost based on Medicare reimbursements across the country. So those practitioners, those gastroenterologists, pancreatic disease specialists who are practicing across the country will be evaluated based on the cost of all of their peers nationally, and Medicare will be looking at that national mean cost, and those practitioners who are even one standard deviation above that national mean could see their payment adjusted. Now, why is reporting Medicare's PQRS optimally and improving cost efficiency for the value modifier so important? Well, one of the reasons for the renewed focus of Medicare on value-based payment is that the Medicare population is increasing exponentially with the influx of the baby boomers, those born between 1945 and 1965, are rapidly entering Medicare eligibility at a rate of 10,000 new potential Medicare eligible patients per day. This trend will continue for the next 15 years, with the highest spike coming within the next 5 to 7 years. Because of that increased patient population for the Medicare channel, and at the same time, a aligned reduction in the number of employed workers who are able to support and sustain that growing Medicare population, CMS is tasked now very urgently to reduce the cost of care while at the same time maintaining quality of care. So quality of care will be directed by reporting of PQRS, reporting criteria for all physicians, and what pancreatic disease specialists report this year in 2015 will be the data that CMS will use to determine payment starting in January 2017. Now, many of the pancreatic disease specialists on the line tonight or joining the webinar this evening may be thinking, well, we work for large academic medical centers, and we know that other team members, perhaps nurse practitioners, physician assistants, medical assistants, or other HIT professionals are extracting the data from our current EMR systems and are reporting those PQRS measures on our behalf. And that certainly may be the case. But those practitioners who are not focused or aware of which measures you're reporting will perhaps not be in a position to be optimally reporting those PQRS measures or as accurately or completely reporting those PQRS measures. And it's also important to know that as these data needs become more robust for Medicare and the commercial health plans, those commercial plans and payers will be looking more and more granularly at data for specific specialists. And so it's very important for gastroenterologists and pancreatic disease specialists to report quality measures that are pertinent to your specialty. Now, healthcare transparency and the visibility of every practitioner's cost and quality is also driving the need for the best data possible. Many practitioners are very surprised to learn that their cost and quality data is now visible on a number of websites and through various apps that are now available in the public domain. Medicare.gov has a new Physician Compare website. This website is up and running as of last year, and anyone can go to the Physician Compare website, type in the name of a physician, and get data on whether that physician is reporting PQRS quality measures, whether that physician is using a meaningful use electronic medical record, and e-prescribing, and other information about that physician's practice. In the very near future, cost data and how that physician compares in terms of his or her Medicare cost will also be available on the Medicare.gov Physician Compare website. The Healthcare Blue Book is Blue Cross Blue Shield's consumer comparison website for healthcare cost and quality, and other healthcare data transparency informational sites include United Healthcare for Me, the Healthcare Cost Institute, which is a collaborative of Medicare, Aetna, and Humana, two pairs that recently merged, Kaiser, and United Healthcare. So this will be an especially interesting collaborative to follow, because this is an opportunity for a number of commercial payers as well as Medicare to share cost and quality of care data. For Medicare, physicians now have access to Medicare's Quality Resource Use Reports, also known as the Physician Feedback Reports. Our PQRS and Value-Based Payment Guide has much more detailed information on how to access these reports. But for those pancreatic disease specialists joining us tonight who are not familiar with those reports, now would be a great time to work with your directors of quality and your health systems to get copies or access of those to those reports, so you could see how your data compares with that of your peers. And finally, at the bottom of the screen, we wanted to share with you this evening this iPad app. This is an app now available in the public domain. It's free of charge. You cannot access this app on an iPhone or on a desktop. You must use an iPad to access this. But this app has actually very ingeniously taken publicly available data from 2012. It's a little bit dated, but the data is from the CMS website, and MicroStrategy has developed this very clever app that easily allows health systems, employers, other physicians to access data on themselves and other physicians. And you can see in this example, which is following a dermatologist who graduated from Northwestern University Medical School and practices in Northbrook, that in this particular example, this dermatologist was reimbursed about $1.25 million for Medicare services in 2012. Those services involve 44 different services or procedures affecting 1,137 patients. How this provider compares on the right-hand side of the slide shows that this particular physician was reimbursed on average about $1,100 per Medicare patient. But that, compared to his peers, was quite a bit significantly more costly, because that $1,100 per patient was significantly higher than the $251 per patient averaged by his peers across the country. So this is just a quick example of some of the data that is available right now comparing cost and quality of professionals, healthcare professionals, and this data will become even more robust and readily available in the near future. I'm going to pause for just a moment to see if there are any questions, and so far I am not seeing any questions, and so we'll continue on with the presentation, but please feel free to raise your hand or type in any questions that you may have. Now, how will this data be used and the quality and cost of physicians be used to compare physicians? Well, unfortunately, this data can be your sword as well as your shield. So it's very important that the data that each practitioner amasses, it reflects the very best quality and cost scores possible. Already, many commercial payers, and this slide illustrates that United Healthcare, in this example, reduced one of its networks in the Northeast by some 700 doctors based on what they described as inferior quality and cost data. On the right-hand side of the slide, you can see that most of these plans are Medicare Advantage plans, like the AARP Medicare Complete Plan, Medicare Solutions. Many of these large national payers, United Healthcare, Cigna, Aetna, Humana, have very large Medicare Advantage books of business. In some markets, like Pittsburgh and Florida and California, Medicare Advantage networks are more of a market force than in other markets. But certainly what's driving many of these large commercial payers to narrow their networks is their interest in reducing cost for Medicare patients, and they're doing this by narrowing networks to those physician groups and health systems they believe will provide the optimal value. An example of this is a case study here from Cigna. Cigna was one of the early commercial payers involved in collaborative accountable care organization agreements. You can see from the map shown in green, the states that are indicated in various shades of green, that Cigna has a number of ACOs across the country, particularly robust, as you can see in Texas, and as one example. But Cigna is an example of just one large national payer that is employing ACOs predominantly to manage its Medicare Advantage book of business, and in many cases a significant amount of its commercial book of business. United Healthcare alone is employing about $65 billion in ACO contracts this year and in 2016. So it's very important to see that while ACOs have shown success in reducing ER visits and hospital visits, they also have been effective in reducing cost and improving quality. And the focus of many of these value-based initiatives from large commercial payers like Cigna, as we can see in the lower right-hand corner of this slide, has been to reduce the cost of specialty care in specialties like gastroenterology and oncology. So it's important to, again, be aware of your cost and quality data and to be prepared to use that data to your advantage. Now, returning to Medicare's physician quality reporting system, what is it? How is it used? We know that PQRS is Medicare's pay for performance program for physicians and other eligible professionals, including nurse practitioners, physician assistants, and other healthcare professionals. What's important to know, and what may be new to some of our our physicians joining us on the phone this evening, is that PQRS is now required. It's no longer a nice-to-do program that will allow you to get an additional bonus or increase in payment. It's now a requirement for all healthcare professionals to report PQRS quality measures to the optimal ability of that practitioner. And any practitioner who is not correctly or optimally reporting PQRS will see a decrease in payment. In worst case scenario, any physician or other practitioner who does not report PQRS at all, simply ignores it, or does not report it accurately enough to achieve at least an average quality score, will see very likely a payment adjustment. Now, what happens to those physicians who do not successfully report PQRS? Well, in 2015, physicians in groups of 10 or more who do not successfully report PQRS will be subject to a payment adjustment of a -4% across all of their Medicare billables, and that payment adjustment will apply in 2017. Based on other quality factors such as reporting meaningful use of electronic medical records, physicians in groups of 10 or more could see as high as a -9% payment adjustment based on not reporting PQRS, and by doing that, they would see a payment deduction based on lack of reporting PQRS, as well as a payment deduction in their value-based payment modifier score, because that includes a combination of PQRS and cost. And if they're not reporting meaningful use of electronic medical records, they could be looking at potentially a -9% payment adjustment. So how does a gastroenterologist or other specialists report PQRS optimally? Well, one approach is reporting a measures group specific to a disease state. For gastroenterologists, fortunately, CMS offers two measures groups, one for inflammatory bowel disease and one for hepatitis C. If a measures group exists under the PQRS reporting system, it's an easier adjustment for physicians. It's an easier way for physicians to achieve PQRS success, because each eligible professional would only need to report that measures group on a sample of at least 20 patients, a simple majority of whom must be Medicare traditional fee-for-service patients. But the other patients in that sample of 20 could be commercial patients or Medicare Advantage patients. So it's important, if you're a gastroenterologist, to consider the opportunity of reporting a measures group such as inflammatory bowel disease or hepatitis C. That would be not the only approach to reporting PQRS, but likely the easiest approach. And we, in our Division of Healthcare Policy, have actually partnered with the American Gastroenterological Association, as you can see here on this slide, to develop a guide on correctly reporting the PQRS measures group for inflammatory bowel disease. All of the 7 measures shown here are among the measures in the inflammatory bowel disease measures group. And again, a gastroenterologist would need to successfully report all 7 measures in the group during a Medicare patient visit, or it could be a commercial patient visit on at least 20 patients. But what happens if you're a pancreatic disease specialist? And unfortunately, currently, there is no measures group specific to pancreatic disease. Pancreatic disease specialists do not have a pancreatic disease specific measures group. So the option available to pancreatic disease specialists would be to choose from a list of about 300 current PQRS measures the best available or cross-cutting reporting measures that would apply best to pancreatic disease. Because there is not a measures group, pancreatic disease specialists would need to report at least 9 individual PQRS quality measures in 2015 to avoid a payment reduction. And those 9 measures should be reported on 50% of all of the applicable Medicare patients. And by applicable, we mean those patients with a diagnosis or disease state that would align with the reported measure. The best time to report is now, and so we are going to be talking about very shortly, and I'll be turning the presentation back to Dr. Conwell to talk about a new pancreatic disease set of measures that we will be bringing to you and other pancreatic disease specialists. Dr. Conwell, would you like to speak to the pancreatic disease measures that you will be spearheading with these other organizations?
Absolutely. Thank you very much, Carol. And I want to thank everyone for staying on the line. I know the hour is late and we've all had long days. So what we've done is we've gone through, we had a working group called the Scorecard Working Group from Pancreas Fest 2014, and we worked on going through a lot of the quality measures, myself and Dr. Wickham. They're around 300 measures, and we've kind of crystallized things down to try to see which measures were best available or kind of cross-cutting, very similar to what was done with the IBD group, and we've actually crystallized it down to several. And what we're going to be looking for is just some endorsement from some of the key pancreatic and surgical and endoscopy societies, the APA, the American Gastroenterology Association, the ACG, CAPER, ASGE, and some of our surgical societies that have also partnered with us at Pancreas Fest and also at the APA meetings. So these are the proposed PQRS quality measures options for pancreatic disease specialists. And as what you will see, I'm going to just stick to the left side of the screen and just list the measures. And we believe some of these you will see are associated with pancreatic diseases and can easily be measured and used in that 50% of the Medicare patients that we're going to be seeing in our pancreatic centers of excellence. The first one we saw was screening or therapy for osteoporosis for women 65 or older. We know there is an association with osteoporosis in pancreatic disorders, especially chronic pancreatitis, and we felt this would be a very easy one to be able to assess, especially in women. The next one was pharmacologic therapy for men and women age 50 and older. Colorectal cancer screening, obviously something that we all should be assessing in our patients. Screening colonoscopy adenoma detection rate, and that would be very easily to report. Hepatitis, one-time screening for hepatitis C for patients at risk, and of course this includes those patients born between 1945 and 1965. Another measure domain, communication and care coordination in terms of medication reconciliation, and this is something that we all do in terms of meaningful use, so we felt that would be a very easy one to pick up when you're seeing your patients in the office. Biopsy follow-up, not uncommon for a lot of our patients with pancreatic disorders, especially those with pancreas masses or those that are undergoing colonoscopy, to have a biopsy and making sure the follow-ups were done. Appropriate follow-up interval for normal colonoscopy in average risk patients. Tobacco use, screening and cessation intervention. The other one was unhealthy alcohol use. These two are very important for us. Obviously, we always counsel our patients in tobacco cessation, and also we always screen our patients for unhealthy alcohol use. So these, as you can see, are very appropriate for pancreatic disease centers of excellence to be monitoring in the patients that we see in our centers. Pain assessment and body mass index, of course, are important. A lot of the patients with chronic pancreatitis especially have pain, and of course patients with acute pancreatitis can have some pain, and pancreas cancer. BMI is important, and of course with this association with some of the severity, obesity, and its relationship to acute pancreatitis severity. And these two we felt were very easy to add in terms of preventive screening for influenza immunization and pneumonia vaccination status for older adults. And these were also shown in some of the other disease groups that we felt this would be a very simple one to get, and obviously it's important for an older age population. Documentation of current medications in the medical record, another meaningful use measure that we felt could be very easily obtained in our patients.
Dr. Conwell, any other comments you'd like to make about the proposed pancreatic disease measures for the Pancreatic Disease Centers of Excellence?
Yes, we have submitted an abstract to the American Pancreatic Association meeting that was accepted as a poster presentation, and it has even more measures on it, and these have been crystallized down to the ones that we've gone over. We do plan on submitting a survey monkey to get some voting from the different societies and people that attended the Pancreas Fest, and especially the ones that are listening tonight, to get some endorsement, because we do want to move forward with this at least flashcard, and then over the ensuing year or two develop some more formal measures similar to what the IBD group and hepatitis C group has done. And we do plan on working with our partners at the AGA. The AGA has a portal. They have worked with the legal department at AbbVie to get the hepatitis C and the IBD PQRS measures through CMS, and so we think that we should just follow them along their pathway and work with the AGA to get it done for pancreatic centers going forward. So just you'll be hearing more from us going forward. But I think this is very important for all of us, as the pancreatic centers try to take their rightful place and be recognized going forward with quality metrics. It's very important for us, obviously, in terms of making sure that we are delivering the best value to our patients, and we can actually measure that value to our patients. And a big part of that value assessment is the quality that we deliver to the patients that we see in our academic centers. So if there's any questions, feel free to type out your questions or responses, and we'll be happy to try to answer them.
And Dr. Conwell, I'm looking to see at this point if there are any questions, and I'm not seeing any as of now, and we certainly look forward to questions, any additional questions. Thank you, Dr. Conwell. Excellent summary of the status of PQRS and quality reporting, and the need for pancreatic disease specialists to focus, especially if you are part of a pancreatic disease center of excellence. It's very important, as Dr. Conwell noted, to be in the best possible data position and have the optimal quality and cost scores that will position you for that success as a center of excellence. So as a quick recap, and because it is getting late, and we'll quickly summarize and open it up for questions, it's very important for pancreatic disease specialists and their teams to ensure successful reporting of PQRS to avoid a financial penalty, as well as to have an optimal quality score.
Carol?
Yes, Dr. Conway.
Dr. Yadav has a question.
Oh, sure.
And I think Dr. Yadav is able to type that question out, if I recall.
And Dr. Yada, if Amir would like to unmute you, you could certainly just ask that question. Dr. Yada, are you able to ask your question?
Can you hear me?
Yes, we can hear. We can hear you, Dr. Yadav.
Yeah. Good evening. Thank you for this wonderful session. My question is, I can understand that you have picked these questions from already established measures.
Yes.
What about, or it will be really nice to see what we can do as a community to incorporate measures that would be more specific for pancreatitis patients. Say, for example, osteoporosis screening in patients who are 65 and older may not be as pertinent to pancreatitis patients because a small fraction of patients will fall in that age group.
Correct.
Screening for, say, osteoporosis, exocrine endocrine insufficiency are measures that should be applicable to all chronic pancreatitis patients, as an example.
Correct.
So is there something in process, or that may be something to work towards
Right. Yes, and that's a very good question, and I'm so glad you asked it, because this is what we call the best available quality measures that are currently accepted by CMS. I want Carol to further emphasize this. So what we did, Dheeraj, is we went through the currently accepted quality measures. There's around 300 of them, and we combed through them to see what we potentially could use that are closely related to pancreatic disorders. And your point is well taken. There are no pancreas-specific quality measures. So the abstract that we put together, that the scorecard working group put together, the title of the abstract to the APA is, are the current PQRS quality measures sufficient for an academic pancreatic center of excellence? And the answer really is they are not. And that sets us up for the first scorecard, the first assessment, which are the best available ones that are in the acceptable list. But then we as a group need to sit down like the IBD group did, like the dermatology group did, and say, exactly, what are the pancreas-specific quality measures that we should be checking for? And like you said, exocrine insufficiency, metabolic bone disease, and we need to define those quality measures for our specialty pancreatic centers. And you're exactly spot on. So we're moving toward it. So the next phase will be to develop pancreatic disorders specific measures, and that's going to take working groups to come together and decide what those specific core things are.
Thank you.
So Carol, you want to further emphasize that in regard to how it was done with the IBD group? Because what's happening here now is we have just some general cross-cutting best available measures, but then we want to develop some pancreas-specific ones. Can you tell us how it was done with the IBD group first, and how you got to this measures group that's specific for IBD?
I can explain somewhat, Dr. Conwell, absolutely, and you did a very nice job of summarizing the situation that Dr. Yadav asked about, and it's such a pertinent question because, as Dr. Conwell was just saying, unfortunately, some of the specialists historically have not put together measures groups. This inflammatory bowel disease measures group, depicted here on the screen, was developed by the American Gastroenterological Association, and it took them several years to develop this using working groups and committees such as your academic Pancreatic Centers of Excellence working group that Dr. Conwell is leading and helping to support. So with that, it takes a great deal of time, as you can imagine, to develop quality measures, typically at least several years. So how the AGA did it is they looked at the clinical evidence based on what was available from clinical studies, and they proposed a series of measures. The measures typically, and you might say, well, corticosteroid sparing therapy, that makes sense. Ensuring that patients have a TB test before initiating anti-TNF therapy, that makes sense. Could these measures be more robust? Absolutely. But what happens during the consensus building process, and you can see from this measure development process that the AGA developed the measures by committee, by consensus, based on the best available clinical evidence. They then took those measures to the NCQA, the National Committee for Quality Assurance, and the AMA Physician Consortium for Performance Improvement. Now, there are ways to fast-track measures, so in cases where there are no specialty developed measures, such as measures for pancreatic disease, there are different pathways that could be used to try to fast-track some of those measures, but at minimum, the Specialty Society would have to agree, submit the measures as a measures group, and ideally go through the political process of gaining commitment from and consensus from the AMA, PCPI, and from other groups. So I think your goal of using the APA and the AGA to support these measures and to help you shepherd these measures through an established AGA process is likely a very good approach. But typically from the time you first need the clinical evidence to support a measure, and then you need to go through the process of testing and validation and agreement and consensus. So typically it can take a 2 to 3 year process to develop a measures group, and that's one of the reasons why, at least initially, in order for pancreatic disease specialists to have the best available, maybe not optimal, but the best available measures, the goal was to put together the group of measures shown here that Dr. Conwell just reviewed with us, to at least for the next several years have a measures group that would help to reflect the importance of pancreatic disease specialists and show measures that were as close as possible to pancreatic disease needs to support your specialty. So unfortunately, it's not an easy process, but it's a necessary process. So it will be important for, as a first step to have the best compilation of clinical evidence to support the measures that you will be offering, such as measures around exocrine, pancreatic insufficiency. Another pathway that just opened up this year from Medicare is that you could actually develop your own patient registries, either under the banner of CAPER or APCO, or at your individual institutions. and you could actually develop or use a qualified clinical data registry. The AGA registry is a CMS-approved registry. It also is a qualified clinical data registry. And that's a process whereby, for example, if you had a qualified clinical data registry and you were reporting measures such as exocrine pancreatic insufficiency, you could report non-PQRS measures, measures that you developed and were recognized by a group like the AGA or the APA, and you could actually report measures and get partial PQRS credit for measures that were not yet recognized as PQRS measures, but were recognized by another specialty group. So that could certainly be part of your pathway too, to get started on developing measures that are more specific to pancreatic disease.
Okay, so Carol is flipping through those measures, and we have a question from Dr. Peter Muscarella. So can we have Dr. Muscarella unmuted so he can ask his question?
Hi, Darwin. Can you hear me?
Yes, we can hear you, Pete. How are you?
I'm good. I'm sorry I missed you in Pittsburgh, but I'll tell you about that later. Not so much a question, but I think it's great to develop these. There are surgery-specific PQRS measures that we report, like on perioperative antibiotics and things like that.
Mm-hmm.
So
Yes.
as the group moves forward, do you imagine dividing these up by disease processes like acute pancreatitis, chronic pancreatitis, etc., but also dividing them up by surgery or medical evaluation and things like that? Because just sitting here right now, I wrote down a few of them. I can think of a bunch of measures for all kinds of pancreatic diseases that would be pretty good, like you know, just doing severity scoring, documenting severity scoring in people with acute pancreatitis. That's like the most important thing you could do. So
Yes. Now, I think most of these, and I think that's good. I think we're going to need to have, going forward, we're going to need to have representation from all the different societies that take care of pancreatic disease, and that's going to have to include surgery, endoscopy, medical pancreatology, radiology, to come together and come up with some quality measures, because I think right now we're thinking mostly about outpatient measures. I think where most of this is stemming from. Is that your thoughts, Carol, where most of these are coming from? Or there are outpatient measures?
Yes, I think that's correct, because PQRS is a Medicare Part B in-office outpatient measures group. So for hospitals, there certainly are a separate set of quality measures related to readmission and preventing, preventable hospital-based infections and so forth. But Dr. Muscarella raises a very good point. There certainly are measures that are within PQRS, such as the perioperative use of antibiotics. There used to be a perioperative measures group. Unfortunately, that's no longer available. So there are some, pre-surgical perioperative preventive measures that certainly could be used as well, but typically, most of the measures that we saw that we were thinking would apply to the largest number of pancreatic disease specialists were the measures that you can see here on the screen, Dr. Muscarella. But your suggestions for severity scoring, CT imaging, no antibiotics, nutritional support. These all are very valid and make perfect sense,
Right.
and certainly mirror very similar measures that other specialty groups have developed. So you're very much on the right track in suggesting this approach.
Right, and we're going to be and we're going to be looking for people, Pete, to volunteer to be on the committee, and I would love for you to join us because we're going to need some surgical representation on these committees. This is going to take a couple of years to develop. There'll be intermittent meetings, and so we're going to, because the surgeons I think are ahead of us with the NISQIP database, and are ahead of us, especially the medical pancreatology community, in regard to some of these quality scores and assessing these types of things. So we definitely need the surgical representation. So feel free to join us and help us get this done right. Because I never, I think thinking about disease specific within pancreatic disorders is very important, because I think pancreas cancer is going to be different from acute pancreatitis, which is going to be different from chronic pancreatitis. So there may be some choices to be made based on what you're seeing. Some of the things will be consistent or uniform across the various pancreatic disorders, but some of these may be very specific for the particular pancreatic disorder, like you're saying, in terms of CT imaging for acute pancreatitis, and something may be different for chronic pancreatitis, like osteoporosis, or something different for pancreas cancer. So I think those are great suggestions.
Yeah, I mean, to your point, these measures here could apply to patients with pancreatitis, but a lot of them, if you look at them, they're just things that you should do almost for anyone, or who are chronically ill or a certain age, things like that. Probably we want to have specific, pancreatic disorder measures. I mean, that's the whole, I guess, but
yes. And that's exactly correct, and that's what Dr. Yadav's point was. He said, and he was saying, well, this is just a step toward the next phase, which is going to be pancreas-specific ones, and these are just choosing from the approximately 300 lists that are already approved, and none of them are pancreas-specific. This is essentially just good care of people that have, chronic diseases or problems, and trying to get the closest thing we could that may be cross-cutting to pancreatic disorder. So you're right on.
Absolutely, and the measures that you mentioned specific to pancreatic disease are, when you're thinking about it, and I think these measures that Dr. Muscarella mentioned would be a great start, because these are, as Dr. Conwell said, these measures here that we're showing on the screen are stopgap measures, because no specific pancreatic disease measures currently exist, and the goal was to cover pancreatic disease specialists to the best capacity possible over the next few years, so that you could actually report something that would be somewhat meaningful and not be in a situation where your quality scores are low because you're not reporting or underreporting, but certainly moving toward the goal of having more pertinent, and robust measures. And the measures that you mentioned, Dr. Muscarella, are measures that other specialists have chosen similar measures because they would be relatively easy to measure, easy to validate, and so it's important when you're setting up your measures to think about those requirements too. That a measure that you can easily test and validate will be easier to get approved. So. Very good discussion. Are there any other questions before we move to summarize? Just checking to see if there are any other questions from the group. this
Well,
evening.
these have been great questions, and this has been a great discussion. We've had some good discussion, so I really appreciate everyone participating. And so, Carol, let's try to wrap it up.
Wrap
And
it up. We will,
it's been
Dr.
great.
Conwell.
Yeah.
Absolutely. Since we only have 3 minutes, this explains, we've talked a lot about quality measures and PQRS quality, which is really the heart of the presentation this evening. But we also wanted to touch base on the value modifier amount that will be paid based on a combination. And this slide is directly from CMS, and it shows, as Dr. Conwell was indicating, that if a pancreatic disease specialist is reporting those 9 individual measures, then at least 3 different domains of care must be quantified. So they don't have to, you would not need to have 9 individual measures that cover all of these domains, but at least 3 domains such as clinical care, population health, and care coordination, for example, would have to be covered among those measures. All 9 measures could not be care coordination measures, for example, but would need to reflect 3 different domains. So your quality of care score based on your PQRS reporting will be combined with the total per capita cost, and that total per capita cost will be based on your Medicare Part A hospital charges or payment and your Medicare Part B physician and ancillary services payment. And again, the cost of care will be compared to the cost of pancreatic disease specialists across the country. So if you do not report PQRS, and looking at the right-hand side of the slide, the waterfall here shows non-PQRS reporters will get an automatic payment adjustment. But what happens if you are reporting PQRS, or at least reporting some PQRS measures through your institution? Well, looking at the group of physicians with 10 or more eligible professionals, optimally, if you are in the upper right-hand quadrant here and you are optimally reporting PQRS quality measures, you could be considered in the high quality sector, and that could provide or make that pancreatic disease specialist eligible for a +4 factor. So in other words, if you're in the highest quality sector, you could be getting a 4-fold payment increase that would be based, quite frankly, on the payment decreases that other physicians would be leaving on the table because they have not optimally reported PQRS. However, if we move across to the left-hand side of this bar chart, you can see that if your quality is considered only average, then your payment factor, would actually decrease to a +2 factor. And you would only retain that 4 or 2 times payment factor or modifier if your costs are low. If your costs are average, moving down the bar chart, you can see that if you're a high quality provider but your costs are average, you would get a +2% factor. If you have average cost and average quality, then you would end up with 0%. So even if you're in the high quality sector, moving again to the far right-hand side of the slide, if you have high quality but your costs are high, you would end up at a net neutral position. So this slide really depicts the importance of not only optimally reporting PQRS, but also ensuring that your costs are within that national mean cost of care. One way of assessing how your practice or your institution stands in terms of cost of care would be to access your physician feedback or quality resource use report, also known as the QRUR. Your quality officer or HIT team members should be able to help you get access to that report and determine where your particular practice would, would fall in that sector, that national average of cost and quality. So would highly suggest that you take a look at that report. This provides another sample of what your QR-UR report would look like. So not only would you see that scatter dot, cluster shot that shows you where your practice ranks, but the QR-UR report is quite robust. It's about a 15-page report, and it would actually spell out, this is an example of what a report might look like, and on the y-axis you could see whether your costs are lower than your peers, or higher than your peers. And so that also will provide you with a snapshot to understand the cost of care. This slide is a very busy slide, and this will be our ending slide for this evening. But what we also wanted to convey is the importance of value-based payment moving forward. What many physicians may not realize is that the Medicare Sustainable Growth Rate calculation that for the last 17 years, before I came to AbbVie, I was an attorney with the American Medical Association, and I was their director of advocacy. So for the last 17 years, medicine has fought to ensure that Medicare did not provide unsustainable payment cuts to Medicare reimbursement. What the Congress did, and this was really quite stunning, is in April, by a majority, an overwhelming majority of both Republicans and Democrats, our Congress passed the Medicare Access and CHIP Reauthorization Act of 2015, also known as the MACRA. And what the MACRA did is that for the next 10 years, as you can see, moving along the bottom of the chart through 2026, Medicare will now be paying all physicians and eligible professionals based on value-based payment. PQRS, meaningful use in value-based payment, will continue as it is now through the end of 2018. In 2019, all of these quality and value programs will be rolled into one program called the Merit-Based Incentive Payment System, or the MIPS, and that will comprise meaningful use of electronic health records, PQRS quality measures, and value-based payment. And the payment cuts and incentives will continue being capped at a -9% potential loss starting in 2022. But what's very interesting to note in the purple bar is that any physician group that is part of an alternative payment model like an ACO or a bundled payment where your health system is taking a certain amount of risk for Medicare patients will be automatically eligible for a 5% lump sum bonus. So you can see that Medicare is going to be highly driving patients into accountable care organization types of models, and those specialists, pancreatic disease specialists that have the best quality and cost scores will be the best situated to be performing in those high value health systems that Medicare will be rewarding with this lump sum bonus, and that commercial payers will also be looking to provide care for their networks. So that ends the presentation, and I'd certainly be, I know it's very late, but would certainly be more than happy to stay on and answer any questions from the group. Dr. Conwell, any parting remarks?
Okay, thank you very much, Carol. And I want to thank everyone, all the attendees, for staying on and listening. This is going to end the 2 planned webinars from Pancreas Fest 2015. I want to thank CAPR for hosting the webinar. I want to thank Carol for educating us on the PQRS measures. We will be sending out a survey monkey, getting some voting and seeing your responses to help us move forward with this. We also will be having a breakout session at the APA in San Diego, but we will be moving forward after we work with our partners at the American Gastroenterological Association and try to move forward with these measures. And as I said, these are obviously not the best measures, but these are the best available that we could use to kind of get things moving in the right direction. But over the next couple years, we'll be working with AbbVie, the AGA, our surgical partners, endoscopy partners, and other societies to try to determine pancreas-specific measures that we can use to develop our own measures group to help us provide high value to our pancreas patients as they come and see us in our academic pancreatic centers of excellence throughout the country. So thank you very much, and good night, everyone. And again, Carol, thank you very much for all the hard work you've put into making these presentations possible. I want to thank Amir for setting up the webinar, and again thank Caper, and we want to thank Dave Whitcomb for all the work he's put into making this possible. So everyone, have a good night and drive home safely. Thank you.